afternoon. My name is Daniel Doan. I'm Associate Director for Training and Development at the Philip R. Lee Institute for Health Policy Studies. I'm delighted to welcome you, the UCSF community, to the 10th Chancellor's Health Policy Lecture. This series has enabled us to bring outstanding health policy leaders to UCSF to focus on critical current health policy issues and highlight the vital role that health policy plays in the lives of our faculty, staff, fellows, residents, and students, and the impact it has on health and health care. I'm honored to introduce our Executive Vice Chancellor and Provost, Dr. Jeffrey Bluestone, who will introduce our distinguished 2012 lecturer. Ladies and gentlemen, please welcome Executive Vice Chancellor and Provost, Jeff Bluestone.
Thank you, and good afternoon, everybody. It's really great to see this fantastic turnout. Those of you who may remember that last September, Dr. Judy Ann Bigby, Secretary of Health and Human Services for the Commonwealth of Massachusetts, spoke here about implementation of the pioneering health insurance reforms in that state. And that really has prompted us to really think about how do we think about it here in California. And so on that note, we were very lucky to be able to get our speaker today. And so on behalf of myself and the Chancellor, I want to welcome Senator Thomas Daschle here to our campus, who's going to broaden this conversation to talk about healthcare reform and how it affects every state and on a national level. For those few of you who don't know who the senator is, Tom Daschle is the former U.S. Senator and Senate Majority Leader from the state that has Mount Rushmore, South Dakota. Senator Daschle has had a broad-reaching public service experience. In 1978, he was elected to the U.S. House of Representatives, where he served for 8 years. And then in 1986, he was elected to the U.S. Senate, and 8 years later became the Democratic leader. Senator Daschle is one of the longest-serving Senate Democratic leaders in history, and I think maybe the only one to serve both as the majority and minority leader, so quite a distinguished past. Since leaving the Senate, Senator Daschle has continued to be involved in a number of issues, and healthcare issues being at the forefront. He's been involved in informing many discussions and many leaders on these issues. He was absolutely instrumental in working with the President and Congress during the healthcare reform deliberation. And in fact, the New York Times called Senator Daschle the most influential advisor to the President in the healthcare debate. He's written extensively on this. A couple of memorable books that he's written are the Getting It Done, How Obama and Congress Finally Broke the Stalemate to Make Way for Healthcare Reform, and a book he co-wrote entitled Critical, What We Can Do About Our Healthcare Crisis. A very substantial body of work. So on a personal note, I first came to meet the senator some 7-8 years ago now, when the Prop 71, the stem cell initiative, started in California. And he was generous to come and work with Bob Klein and others to really get that proposition off the ground. And it really showed me his commitment and dedication to all aspects of healthcare, from the most policy-oriented really down to the science that's really going to help to revolutionize it. And this passion and commitment across the whole spectrum is really laudable. So currently, Senator Daschle is a senior policy advisor in the law firm of DLA Piper, where he provides clients with strategic advice on public policy and issues. He's working on a national level and international level on healthcare, climate change, energy, trade, financial services, and telecommunications. So quite a broad portfolio. So please join me in welcoming Senator Tom Daschle here to talk to us.
Thank you very much. Dr. Bluestone, thank you very much for that generous introduction, and thank you for your warm reception. It is such a pleasure to be here, and I am very grateful for the opportunity. I listened very closely to Dr. Bluestone's introduction, because in this business you get introduced in so many memorable ways at times, and I appreciate his kindness in using the words he did to describe my career and my contributions. I was introduced once as a model politician and a model South Dakotan and a model United States Senator and a model majority leader My wife Linda was in the audience as she heard this introduction and later showed me the word model as it's defined in the dictionary, and there it's defined as a small replica of the real thing. I listened carefully. Did you hear model? I didn't, so I appreciate that especially. But I also want to thank Chancellor Hellman for changing her schedule. She's supposed to be in New York right now, and she's here, and it means a lot to me that she was able and willing to do that. And I wouldn't be here at all were it not for one of my closest friends, Dick Blum, who has asked me to join him on the Blum Foundation and who cares deeply about education in the state of California. And it's been a privilege and extraordinary experience to be his friend all these many years. And I have to mention another dear friend. John DeLuca is here, and he too changed his schedule to be with us, and I'm grateful for John's friendship and his extraordinary contribution to education and to UCSF as well. But let me say in all sincerity, as I said this morning to the deans and to some students, how incredibly impressed many of us are with what is happening here at UCSF. You have made a mark, and you are making a contribution of extraordinary value to our country and to our people. Your dedication to improving the health and the livelihoods and the quality of life of all our people is recognized, and for that we are extraordinarily grateful. So I thank you and tell you that how appreciative we are of the contribution you make every day. We are in the most transformational moment for healthcare that our country has ever seen, ever experienced. This transformation will take place for a long time to come. Therein lies exciting opportunities and extraordinary challenges. And whether we get it right, and whether we can do this in a way that will continue to move forward in a successful manner, really is up to each of us to better understand the complications that we are addressing and to better and more clearly articulate the vision that we have for healthcare in America. As transformational as this time is, there are a couple of things that, at least for the foreseeable future, probably won't change as much as I would like them to change. The first is that we are a country, arguably the only industrialized country in the world, that doesn't have a healthcare system. If a system is defined as one that would be characterized as having a central decision-making and administrative authority, we don't have one. We have a healthcare marketplace made up of a collage of subsystems, both public and private. And therein lies our strengths and some of our weaknesses. That collage of subsystems doesn't coordinate well, and we're built around silos that are impenetrable in some cases. And so we have to recognize that in not having a systemic approach to better health, we've got to make this marketplace work more effectively. The second characteristic of our healthcare sector in the United States is one that I also hope we can soon change. All healthcare, in my view, looks like a pyramid in any society, where at the base of the pyramid you have good primary care and wellness, attention to health promotion. One works your way up the pyramid and becoming more and more sophisticated, more technologically inclined, until at the very top of the pyramid you have the most technological applications to health today. MRIs and health transplants and all kinds of genomic applications today that we're only beginning to appreciate. Every society starts at the base of their pyramid and they work their way up until the money runs out. In the United States, we start at the top of the pyramid and we work our way down until the money runs out. And unfortunately, it runs out. My hope is that we can create a pyramid with top to bottom care, not giving up the advantages of the technological applications upon which we've come to depend, but to recognize how much more efficiency and how much more value and quality we can achieve if we put more focus on the bottom of the pyramid, as I know many here in this room are inclined to do. I got one supporter here. That really, I don't know what that says for the rest of you, but I won't ask. I would make a few observations about where we are today in the context of the health debate that has now been ongoing for several years. And I might note, parenthetically, that this is a very historic moment. Tonight is the national debate, the first presidential debate. And to my knowledge, it's the first time in history that a portion of the debate will be dedicated exclusively to a debate about health policy. I'm encouraged by that. I'm hopeful by that. I'm hopeful that we'll be enlightened by that as well. But in this polarized political existence, I think it ought to be noted that there is far more agreement than most people recognize about our current circumstances. There is very little debate about the current problems we're facing in healthcare today. I don't know of anyone who disputes the notion that we have a serious cost problem. About $80,500 per capita, twice as much as any other industrialized country. I like to put it in the context of my own lifetime. When I was born, health was 4% of the GDP. When my children were born, it was 8% of GDP. When my grandchildren were born, it was 16% of the GDP. And we're now told by economic forecasters that if I'm lucky enough to have great-grandchildren, it'll be 32% of GDP. That is unsustainable. We know that that trend is one that we simply can't ignore. And about that, there is very little difference of opinion. We also know we have an access problem of some magnitude. About 50 million people have no health insurance. Another 40 million are grossly underinsured. And every year we're told 26,000 people, about 2 per hour, die simply because they have no health insurance in America. That's unacceptable. And there really isn't any disagreement that that is a mark and an embarrassment to this society that we've got to rectify. Increasingly, there is a growing consensus as well about quality. We have islands of excellence, UCSF, in a sea of mediocrity. And we hate to acknowledge that, but Commonwealth consistently lists us last as a society in terms of overall efficiency, quality of care, with the experiences that we now have documented. We know we can do better with regard to quality across the board. And that, too, is something for which there is little disagreement today. There's also, surprisingly, fairly significant agreement with regard to what are the causes. The healthcare sector is the least transparent of all the sectors in our economy today. It's the only sector of the economy, I would argue, where at the time of purchase we don't know what it's going to cost or who's going to pay. We also have to acknowledge we have so much more data on every sports figure in America than any provider in America. And so transparency, or the lack of it, is one of the concerns for which there is widespread agreement. We have too much unnecessary care, driven by a fee-for-service system that rewards volume rather than value, and a recognition that unnecessary care is driven in part because we find it harder and harder to draw that line between a business and a practice. And the more it's a business-driven enterprise, the more the bottom line becomes one of deriving greater and greater profit. And so we've got to recognize that that line has to be one which we all recognize as needing to be addressed. But the volume of unnecessary care continues to grow. The lack of coordination for chronic illness, the degree of time and effort and money we put into administrative costs, now estimated to be somewhere in the 15% range. I like to say, in fact, I don't like to say, but I have to acknowledge that we have a 21st century operating room and a 19th century administrative room. 20% of all of healthcare today is all that is electronically driven. 80% is still paper driven. And we have a serious problem with regard to errors, complexity, duplication, and unnecessary administrative cost as a result. We have fraud and abuse problems that continue to exist. I guess my point is, without going through the laundry list, and I'd add only one more for emphasis, we put far too much emphasis at the top of the pyramid and not at the bottom. And therein, we see a lot of unnecessary costs. And so the combination of all those causes with a recognition of the three major problems also leads most people, Republicans and Democrats, conservatives and liberals, to recognize a reasonably common goal. And that goal is simply and very succinctly stated. We want to build a high-performance, high-value healthcare marketplace with better access, better quality, and lower cost, period. That's really the goal. High performance, high value, with better access, better quality, and lower cost. The debate, the source of the confrontation, has largely been over the role of government in doing this. And therein lies the ongoing debate at all levels of political discourse today. Well, the Affordable Care Act was an attempt to address that goal. It was an attempt to begin to put the pieces in place to allow a new paradigm, a new health infrastructure as we go forward, recognizing that we won't solve this central question of the role of government for a long time to come. But with the Supreme Court decision last July, the construction of the new infrastructure of this new health paradigm is beginning to move forward. And it's, as I said, a very exciting, a very transformational time. And I want to talk a little bit now about the 5 levels where we will continue to see challenges to the construction of this new infrastructure. The first level is the one that probably shouldn't surprise anybody, and that is that we still see a number of issues contested in courts. What is the appropriate requirement of religious institutions regarding contraception? To what extent are the exchange subsidies constitutional? Can we understand what role the Independent Payment Advisory Board will play? And there's a challenge in the courts with regard to that, and I'll come back to that in a little bit. What, if any, limits on physician-owned hospitals should there be? All of those legal arguments are still pending in the courts, and all, depending on the outcome, could have an effect on the construction of our new health infrastructure. The second big challenge is what I call the policy challenge. And there's 2 categories of policy challenges. The first is the obvious one. The legislative amendments and legislation that have been offered to either repeal, and there have been 31 attempts in the House to repeal the Affordable Care Act, or to amend it in a whole myriad of ways. That policy debate will go on for some time, and we will ultimately determine the outcome of public policy in large measure through that process. But a far more imminent and a far more consequential and, in my way of thinking, concerning policy debate will be the one about budget. I won't go into an elaborate discussion of the so-called fiscal cliff that we're going to be experiencing beginning in December. But all one has to recognize is that we are facing calamitous circumstances economically if we don't address it, both on the tax side as well as on the budget side. But therein lies the challenges for policymakers. We have one of 2 choices when it comes to health entitlement spending budgets. The first is to do what so many of us have done all too frequently, and that is to cut and shift. That is, cut the federal programs and shift the costs onto other sectors within our healthcare marketplace. Cutting it and shifting it onto states, onto stakeholders, onto beneficiaries, onto business. We do that with some frequency because it's very definable. We can determine exactly the budgetary impact that it will have on the federal government with great clarity. We can just say we're going to take that amount and shift it onto somebody else. And that, unfortunately, only exacerbates the problem. It's so much better for us to do what I like to call redesign and improve, to go after those core causes of the problems of higher costs, and to address them in a much more comprehensive and global way than simply looking at the Medicare and the Medicaid programs and expecting to solve the problem within the confines of those 2 entitlement programs alone. So that will be the choice that policymakers will have. Will they cut and shift, or will they redesign and improve as we go forward? And that remains an open question. The third level, and the third big challenge, is what I call the administrative and regulatory level. And there is, in some ways, the greatest challenge of all because it's by far the most complicated. And there are three components to that. The first is insurance reform. You've already seen the results of this first tranche of reform with all the changes that have occurred with regard to insurance over the last 2 years. Young people, for the first time, have the ability to sign up on their insurance for their family plan. Soon there will be a complete elimination of lifetime limits, of annual limits, of pre-existing condition. Seniors are going to have far greater access to prescription drugs because we're going to increase the subsidy and close the so-called donut hole that has existed where seniors have been required to pay exorbitant amounts after they've reached a certain threshold. We're going to create new exchanges, new marketplaces in all 50 states where people are going to buy categories of care from bronze to silver to gold to platinum, depending on the actuarial value of the plan itself. All of that and so much more. The multiple loss ratio requiring that 85% of all the value of your premium goes to health coverage rather than to profits or administrative cost. Just an enormous change, a sea change in insurance. And that will continue to unfold over the course of the next several years. The second is payment reform. And here we're going to try to move away from this fee-for-service driven, volume-oriented approach to a far more global, capitated emphasis on quality and on value. And in so doing, putting the emphasis on value and on quality over volume is going to take some doing. We haven't defined how we're going to do that yet. It's going to require a great deal of data management, a recognition that moving to a capitated and bundled approach will have some uncertainty to it. But I'm very confident that it is one of the most important things we can do if we're going to come to a point where we can begin to control costs. The final of the three regulatory and administrative categories is, of course, delivery reform. And here we're going to put a lot more emphasis on comparative effectiveness research, best practices, and approaches to improve quality. That, too, is not easy. And therein lies the challenge for UCSF in particular. So much research and so much opportunity lies in this category of improvement in healthcare delivery. And I know that your researchers and this academic institution will help lead the way in making that a reality as we go forward. Whether or not we do this successfully depends, in my view, on the degree to which we can access and build the construction or build the infrastructure for health IT. It is really critical for us as we consider the implications of all of the challenges we face that we build an infrastructure that allows the utilization of health IT in a much more meaningful way. Whether or not that happens depends in large measure on whether we can overcome the obstacles to interoperability and the business versus practices approaches that are today being employed in too many ways that I think are detrimental to the integration of a broad health IT system as we go forward. The good news is that the Secretary has pretty wide latitude with regard to the implementation of insurance, payment, and delivery reform. And in that flexibility and in that authority, we will find a far greater degree of innovation and I think enthusiastic integration of a lot of these new concepts as we consider the construction of this new health paradigm. The fourth level is the state level. So much is going to happen at the state level. Here in California, within 2 years, you're going to have an exchange where people are going to access insurance for the first time. We're going to have new experimentation with healthcare delivery, but so much of what is happening in these 50 new marketplaces is still up to the states to decide the degree of participation, the degree of engagement, and ultimately the degree of success. And I worry, frankly, about the acceptance and the willingness on the part of many states to engage as successfully as they will need to if this is going to be as successful a national enterprise as it must and can be. California is doing well. Other states are not nearly as far along in its development, but we still have a long way to go in that regard. There's a great deal of uncertainty. About 12 states have embraced implementation of the ACA so far. 10 states have indicated they're unwilling to do it. 28 states are at some level in between. Not sure yet just how they're going to do it or whether they have the authority, some more so than others. The fifth category is probably equal to, if not exceeding in importance, the Supreme Court decision that was offered in July, and that is the outcome of the elections themselves. There is a very profound difference of opinion philosophically between Mr. Romney and the president. Mr. Romney has pledged to repeal the Affordable Care Act the first day he's in office. And so there is uncertainty with regard to the direction health care will take under a Romney administration. For the president, of course, this is a signature achievement. And the consequences of this election and the implications for health reform simply can't be overstated. Today, as we consider the first debate tonight, the president has a small lead, 49, 46, 5, as I understand the most recent polls. But that we're going into the 4 most volatile weeks of any campaign. And anything can happen in the next 4 weeks, but certainly that will be the big question. To what extent can we count on continuity as we continue to see the implementation of the Affordable Care Act unfold? There is also a question, of course, with regard to the Senate and the House. Republicans need 4 seats to take back the Senate. I would say today the election leans in favor of the Democrats for retaining the majority in the Senate, but we know it's going to be a very close margin. And therein lies a lot of uncertainty with regard to the public policy implications that I was talking about earlier. And then thirdly, of course, in the House, the Democrats need 25 seats to take back the House. Today, I would say, to be candid, I would say that it still leans Republican, that the expectation is, the conventional wisdom is, that the Republicans will maintain control. I believe that if it is a status quo election, the one thing we can count on for certain is that this debate about the role of government will continue. I'm hopeful that in spite of the vast difference of opinion that exists today between Republicans and Democrats, that there is potential for consensus around the causes and around the ways with which we can address those causes with the new infrastructure that we're beginning to build. There will be no reconciliation with regard to the role of government. But there is great potential for reconciliation with regard to the goal of improved health care in America going forward. I believe that one of the most important things that we can do is to create more of an opportunity to bring the coalition of the public and private mechanisms that we have in healthcare delivery together in a more effective way. And Congress could take a lesson from the experience that we had in the early 1900s with our monetary system. All through the 19th century, we had many of the same problems with regard to monetary issues and monetary policy that we have in health today. We had a collage of subsystems, both public and private, in our monetary system. They weren't very well orchestrated. And as a result of their lack of orchestration and coordination, we had great uncertainty, great inefficiency, and ultimately great calamity with the crisis of 1907. That crisis in 1907 led to the creation of the Federal Reserve in 1913. I would argue that if we're not going to have a single system within our country, that the time has come for us to look at a regulatory structure that is similar in some respects to our Federal Reserve. I'd call it a health Fed, designed to coordinate these subsystems in a much more effective way. I would argue as well that the time has come for us to depoliticize the healthcare debate. All one has to do is to think about the experiences we had in talking about end of life during the debate of the Affordable Care Act, to recognize how critical it is that we depoliticize this debate. All one has to do is to look at the sustainable growth rate debate that has been an utter failure for the last 13 years as a result of the politicization of the question of reimbursement of physicians today. We've got to depoliticize. I would simply reverse the question. What would it look like today if Congress were responsible for raising and lowering interest rates and dealing with monetary policy as a regular matter of course? Case closed. So I hope that as we continue to progress and as we build this new infrastructure, that we can find ways to ensure that we can build as well an opportunity to further create more certainty and far greater efficiency in our coordinated care model in building this new paradigm for health going forward. Let me also say that you're going to hear a concept that I hope will be viewed in a favorable light as we hear it more often, and that is citizen health. Citizen health implies citizen involvement, a greater opportunity to use data that will soon be available as a result of greater transparency to take better care of ourselves. I like to use my iPhone today as a prop because on this iPhone, I have all of my health records. I have access to all my physicians. I have the results of my last tests just a couple of weeks ago. I have the ability to send this to anybody I need to send it to instantaneously. I have more information in this than I've had in a whole file drawer of documents just a couple of years ago. That's citizens' health. And I'm hopeful that we can create more opportunities for engagement in an informed way as we build on this going forward. I also think that you're going to see a great deal of emphasis on quality in so many different iterations. There's been a good deal of discussion about the accountable care organizations going forward, a recognition that in coordinating chronic illness and in finding better ways to build what I like to call health headquarters, medical homes, and opportunities for us to centralize the data and use it a lot more effectively, that once we do that, we're going to have to figure out ways to make it more accessible. And I think accountable care organizations will give us that opportunity. But rather than have ACOs, I would love to see us consider QCOs, quality care organizations, where iHealth is provided in new applications like this, where things as common as our electronic health records and our ability to make an appointment and our ability to service the claims through insurance and all the things that we can do are done right here. I think that there ought to be more opportunities for cost and quality assessments, more opportunities for reminding chronically ill patients that they've got to take their medicine and give them direction, just as we would with MapQuest on this. More opportunities with apps for providers in operating rooms and in other offering protocols unlike anything that is currently available today. A QCO could offer total consumer price and quality transparency, oversight management of the total experience of care with bundled and capitated payment models and where providers are paid for results and not services. Results and not services. QCOs could collaborate, especially with the 5 major chronic illnesses, to come up with new paradigms for addressing those illnesses in a coordinated way with all other stakeholders within our system, coming up with new ways with which to address chronic illness and creating those protocols. A QCO could also be central in transforming from illness to wellness and bringing us from top to bottom pyramid care. I believe that the QCOs with citizens' health is really the future of healthcare if we take the opportunities that are presented as a result of the Affordable Care Act today. I know that here at UCSF, you're doing a lot of that. I'm excited by what I hear about your progress and about your innovation, about the research, and about the recognition of the success you've already had. And I only can urge you to continue to provide that leadership as we go forward. I have a lot of heroes, and Dick and I have talked about many heroes in American context, but two of my heroes are not American. One is Winston Churchill, and the other is Nelson Mandela. And I think of them often when I think of our challenges in health. Winston Churchill made that famous statement sometime into the onset of World War II. He was lamenting the fact that Americans were slow to respond, and he said, you know, Americans will always do the right thing after they've exhausted every other possibility. And Nelson Mandela once admonished his cellmate, who used to say almost daily, it's impossible to think we'd ever end apartheid in South Africa. It's impossible to do that. It's impossible to even dream that that could be the reality. Nelson Mandela once turned to his cellmate and he said, many things are impossible until they're done. Well, we've tried just about every other possibility, and we've often thought of universal health care with greater value and greater performance based on better access, better quality, and lower cost as almost an impossibility. But I'm absolutely convinced we now have an opportunity to get it done, and you're all a part of the reason why. Thank you all very much.
So we've left some time for questions, and want to make sure that I told the senator that this is not a shy group, so I'm sure there'll be a number of questions, and just when you do ask it, give your name and who you are, and anybody want to ask a question? Go ahead, right there.
I'm Elizabeth Ozer. I'm a faculty member here, and thank you very much, Senator. Great to have you here. I had a question which I'm sure is the more than trillion-dollar question, but when you say we have to depoliticize this whole healthcare process, so I'm interested in any ideas you have for that process, given that we're now about as polarized as we've ever been. And I know even the beginning of this healthcare started with some bipartisan recommendations, et cetera, that then. So anyway, if you could talk a little bit about any ideas in that realm. Thank you.
Well, I guess my point in offering this proposal to create a health fed is in part designed to do that, recognizing that there will always be polarization around this central question about the role of government. But the question is really, should it play itself out on every one of the policy debates that we have, as Congress has to address so many of the challenges that it faces? And I don't think Congress has the capacity, really, to be in a managerial position with regard to health policy on the regular basis required if we're going to do it right. Somebody has to help make these decisions. Now, I don't have any reservations about the role Congress should have in overriding a health fed, or if it were to make decisions for which there were disagreements. But, you know, we made the same decision with the BRAC process, the base closing process over the course of the last 20 years. And it's actually worked reasonably effectively. We depoliticized base closing. California's been affected, to say the least, by that process. But it's worked. And I think we could argue that while monetary policy in the United States is far from perfect, that we have, to a certain extent, at least depoliticized the day-to-day decision-making management of monetary policy today. I believe we've got to do the same thing with the extraordinary challenges we face in these subsystems and our lack of coordination in the subsystems in the public and private sectors today. So that's my first hope, is that we can create an infrastructure that really accommodates depoliticization in a meaningful way. Beyond that, I think what we have to do is to say, look, we know we're going to have to agree to disagree on the implications of a greater role for government as we go forward. But we don't have to disagree on the need for greater transparency. There's widespread agreement on that. We don't need to disagree that there's a significant role that we can play both in the private and public sectors, regardless of the role of government itself, in how we get rid of unnecessary care in this country, how we move more to a value-driven approach to care. And I think that too, so by focusing on the challenges and the causes of the problems we're facing and staying away from this whole question, this notion of increased or decreased governmental involvement, ultimately I think we can get farther down the road. But it's a very important question.
Hi, I'm Catherine Ronji. I'm a physician and researcher, and it's a joy to have you here.
Thank you.
So my question is, in our efforts to develop a national and integrated electronic medical record system, let's just say the VHA, or Veterans Health Administration, electronic medical record system can be upgraded and integrated. And amongst all the barriers to do so, one concern that has been addressed is the significant loss of profitability amongst health IT companies that have made their very living in developing these non-interoperable systems. Well, it's a concern because IT has been a very stable economic bread and butter for the U.S. So I would love to hear your thoughts on how to address that particular issue.
Well, I think it's a major concern. We were talking earlier about this, and when I talked earlier about the fine line between a business and a practice, I meant that in a much more generic way. We have serious questions about what motivates all the stakeholders in healthcare today, and the more it is a business-inclined enterprise, the more unlikely it is we're going to find the kind of cooperative efforts to address this problem in a more meaningful way. But what I think is important ultimately is finding new business models that allow us to reward intellectual property without the proprietary constraints that are so much a part of the current system. And I think over time we can do that. We have to open our systems, and in that openness and creating more interoperability, we've got to find ways to, as others in this space have done. Google is a perfect example. I mean, they've been very innovative in the way they have made the services they provide on the internet much more valuable and much more profitable than they probably even thought possible 10 years ago. But we need to do that same innovative kind of thinking as we consider the interoperability challenges we face in healthcare today. We'll never get to 100% unless we break down those barriers in a way that we haven't been able to do so to date. But the business resistance is really one of the big problems. There's also, I must say, there's a lack of enthusiasm among many providers, hospitals and doctors, who aren't sure that all this transparency is necessarily something they want to embrace. And so we've got other institutional resistance that goes beyond just the technology. But I think it is something we can overcome. At the BPC about a year ago, we spent about a year addressing the challenges we face with regard to health IT and the impediments that exist today. And I'd say the biggest one by far is the one you've addressed, which is the proprietary challenges that we face in making business models profitable, even if they're open systems.
Hi there, I'm Lacey. I'm a fourth-year medical student here at UCSF. And as I launch myself along with my classmates into the residency application and interviewing process, right now we could go into any field we would like to, including becoming a primary care doctor in your home state, or maybe being a neurosurgeon here in the Bay Area. And so I'm wondering, you said the base of your pyramid is primary care, and so I'm wondering, what are some of your favorite ideas about how to encourage our system to be more primary care oriented and our educational system to be more primary care oriented?
Yeah, that's a great question. The most crass short answer is follow the money, because I think it's really a big factor. It shouldn't be as big a factor as it is, but it's understandable. Students who graduate from medical school have extraordinary financial costs that are hampering their ability to lead productive lives for a long time to come. We've got to find ways to lessen that financial burden if we're going to expect people to enthusiastically embrace good primary care going forward. I also think we have to give primary care providers more roles and responsibilities in care than are offered today. I think oftentimes they're now considered almost an afterthought. And we can't, if we really want to create a bottom of the pyramid priority and with greater emphasis on wellness, they have to have greater responsibility and greater opportunities. And I think that's slowly coming to greater recognition. But the bottom line is, whether it comes to education or financial reward following graduation, we've got to ensure that the financial viability of becoming a primary care provider can be realized. And I think today that's an open question. So we've got to address it. The other thing that I think is so critical is that we look at good prevention and wellness as not just the responsibility of the healthcare sector. It really ought to be a community-wide responsibility. We need to do a far better job of teaching nutrition and offering better nutrition in schools in the elementary and secondary level, and creating a new mental appreciation of the extraordinary need there is for good wellness across our community responsibilities. We don't do a very good job of that today, and I'm hopeful that we can begin to put greater focus on that too. It's lamentable that 1 in 3 children are going to suffer from type 2 diabetes in large measure as a result of obesity today. That is preventable. That is something we have to address. That alone ought to dictate bottom of the pyramid care in a more effective way. And I'm hopeful that over time we can change that mindset. But the bottom line is it's going to take resources.
Hello, my name is Zachary Hearns. I'm a fourth-year pharmacy student here at UCSF. My question was regarding, you mentioned the use of health markets and how they'll have tiered programs. I was just wondering, how will these programs address the issues of, since people in general can't actually predict what health issues they might have in the future, how will these markets actually address the issue of underinsurance within a population?
Well, first of all, there will be the basic level of healthcare insurance coverage will be at a 60% actuarial value. We'll go from 60% to 70% actuarial value, 80%, and platinum will be 90%, with a 10% copay required at even the highest level. But in even the bronze level, at the 60% level, there'll be, depending on how you look at it, 10 or 12 categories of basic care that will be required in all the levels. And that basic care will include, for the first time, preventative services and testing. And so it shouldn't be a matter of being uninsured any longer as a result of this redesign. For any insurance company to participate in the exchanges, they will have to offer protection in all the categories required by the law, and will have to spell out in very clear ways how those protections are offered within this basic insurance plan. So we'll have a newfound confidence that we are covered. Today there's so much uncertainty, in part because there's so little transparency. Well, we hope to eliminate that lack of transparency, provide far greater citizen opportunities for citizens' health, and the secret, the basic concept is one that ensures basic benefits regardless at what level you subscribe.
Hi, my name is Timothy Mock, and I'm a second-year student pharmacist here, and thank you for coming today.
Thank you.
So interhealth professional education is near and dear to our heart at UCSF, and I was wondering, what are your takes on interhealth professional collaboration and team-based approach to better healthcare, and how do you see that changing with the implementation of ACA?
Well, I was saying earlier that I'm hoping that we can create a quality care organization, and a quality care organization has as its central premise team-based approaches and collaboration, a recognition that you have a health headquarters, some opportunity for us to coordinate care through a team approach. I proudly recall my time on the Mayo board, and Mayo has put a lot of effort into team-based approaches to healthcare delivery now for many decades, and they've done it reasonably successfully. But I'm hopeful that we can take the lessons learned from those areas where we've already created this new paradigm and apply it in far more settings across the country than we have today. But I think it's absolutely central. That, along with transparency and health IT, are the three major components to good coordinated care going forward.
Hi, this is John Takayama from Pediatrics. I'm a primary care pediatrician. So 2 weeks ago, I went to a funeral for a 1-year-old who passed away, and I didn't bill that. In fact, no tangible results really changed. The patient had passed away. But I was thinking, so there are human aspects about patient care that are not readily measurable. And you might think it makes a difference, but there are no codes or anything, and sometimes you don't even know whether you're making a difference. But I do believe that those human aspects are important, and so given the Affordable Care Organization, the Accountable Care Organization, or the QCOs, how do you value that, the human aspects?
Well, that's such a critical question, and I don't think there's a scientific or an official answer to your question. It's an incalculable value. I talk a lot about the importance of quality and value, and I think value is in part articulated by your question. To what extent do we enhance value in that patient relationship that you have with a provider, and the opportunities that you have to improve sort of disposition and psychological outlook as a result of the intangibles in a good relationship. But as we measure outcomes, I'm hopeful that we can do a better job of incorporating that value and that sensitivity to that relationship as part of the equation. We'll never be able to do it definitively and in a way that fits neatly in some equation. But it has to be part of the overall health experience. And that part is what and again, I come back to citizens' health. It's really what citizens themselves will be able to reflect and value as they consider their own coordinated experience through a quality care organization itself. Creating that positive attitude about the relationship and the experience itself is really essential. It's not quantifiable, but it's invaluable.
Hello, my name's Gavin Yamey. I lead a UCSF project called E2PI, the Evidence to Policy Initiative in the Global Health Group. Thanks for a fantastic talk. I'm a huge supporter of the ACA, a huge supporter of Obama. Obviously, I hope he wins and that the ACA can move forward. But one of its weaknesses is that it isn't truly universal coverage. It leaves out somewhere between 10 and 20 million undocumented immigrants. What's your vision for bringing those 20 million people into the coverage fold?
Well, I should have emphasized at some point in my opening comments how much I believe that we still have a lot of building to do with regard to the ACA, that the ACA cannot possibly be the final word. And your question goes probably to one of the best illustrations of that. We've got to address undocumented citizens in this country, and I think ultimately we will. I don't think it's necessarily something that will happen in the short term, unfortunately, as much as I'd like it to. I think our current system with regard to the way we address those who are undocumented is unsustainable. We can't expect institutions to continue to absorb those costs at an enormous detriment to the financial viability of the institutions themselves. So we can't continue to cut and shift, if I can use that phrase one more time. We've got to find ways to include and to engage that community. I think we may see an opportunity as we look at the next Congress, the 113th Congress, because we're going to be dealing with immigration for the first time in a long time in a serious and hopefully comprehensive way. And I'm hopeful that in that context, we're also going to be able to address the health of these immigrants and find ways with which to begin to put the pieces in place to address it in a more successful and consequential way. You put your finger on one of the big challenges we face. That's a problem that still lies there waiting to be addressed. Thank you all very much. Thank you.